Now, let's look at the evolution of telepsychiatry. Historically, access concerns have driven much of the work of developing clinical telepsychiatry. In April 1924, an imaginative cover for the journal Radio News preceded telemedicine in its depiction of a radio doctor connected to a patient not only by sound but also by a live image. The story of telepsychiatry started back in 1955 in Nebraska. It was the first time a closed-circuit TV system at the Psychiatric Institute was used for the direct transmission of therapy sessions to students at the medical college for educational purposes. The scientific articles back in the early 60s described the use of technology for teaching psychiatry. In 1968, Dartmouth's Department of Psychiatry in the state of New Hampshire was connected to a rural affiliate hospital, resulting in a direct remote patient consultation. In addition, the technology interface allowed for clinicians to operate the equipment themselves. In 1973, Massachusetts General Hospital psychiatrists used TV technology to see patients at a nearby airport. This project was noteworthy for the first use of the term telepsychiatry and the use of remote-controlled cameras to pan, tilt, and zoom, enabling remote body language reading. The pioneer efforts within telepsychiatry development were made in the United States. In the late 80s, telepsychiatry was launched in Canada and Australia to serve primarily underpopulated, underserved rural areas. European experiences go back to the 90s, primarily in Scandinavia, Norway, Sweden, Finland, where large geographical distances make it difficult to get to the doctor. Everywhere we used standardized and expensive standalone video equipment. But within the last decade, we started developing video platforms that operate on personal computers and mobile devices. Telepsychiatry is rapidly growing and constantly changing. So it is important to know when each of telepsychiatry applications was launched and described back in time. Brief outline of oldest and most important references may give you an idea of how long time we have been researching telepsychiatry practiced by standardized standalone video equipment within a variety of settings, patient populations, and mental health conditions. In 1996, telepsychiatry in primary care was proposed as a means of improving communication between primary and secondary care. Harrison and allies have highlighted the advantages of a joint consultation model, in which the general practitioner participates in the patient's consultation at one side with the remote psychiatrist located far away. Such approach does not increase the burden of providers, but does increase the competencies of general practitioners due to regular remote supervision. The project that I launched in Denmark back in 2010, connected my clinic, The Little Prince in Copenhagen, with general practices in outskirts areas of Denmark. It was amazing to see how excited and satisfied the general practitioners were by getting the possibility to improve their competencies due to regular supervision and involvement in diagnostic and treatment course of their patients. Patients, on the other hand, were happy to get relevant treatment in the privacy of general practice, which they were used to visit for years. Many patients mentioned advantages related to no need for travel and diminished stigmatization. The pioneer Telepsychiatry service in psychiatric emergency room describes follow-up consultations with 60 patients in Finland back in 2005. Overall, high satisfaction and reliability was reported. The first descriptions of various telepsychiatry applications for children and adolescents date back to the end of the 20th century, describing both the assessment and treatment of children and adolescents with variety of mental disorders. The American Veterans Health Administration invested time and resources in education and clinical guidelines, particularly related to telepsychiatry-provided treatment for PTSD. Interesting surveys are dealing with veterans' re-entry into regular life, whose fear of stigma reduces help seeking and who prefer technology-based platforms. It seems that PTSD veterans respond better to remote approaches than to personal treatments. It may be due to stigma. Former soldiers, heroes on the battlefields may feel useless in a time of peace, burdened by PTSD symptomatology, but ashamed to be seen in psychiatric clinics. In such situations, telepsychiatry proved to be preferable to traditional in-person approaches. Telepsychiatry saves time and money on the high seas, which is why American military choose it for provision of real-time consultations on distance. Telepsychiatry in assessment and treatment of deaf and hard of hearing individuals is feasible and efficient. As early as 1997, the use of video phone for psychoanalysis of two patients have been described. 1 year later, CBT and psychotherapy supervision were delivered via video link. We know today that online cognitive behavioral therapy shows evidence of efficacy, but often lacks effectiveness in real-world settings when provided without human support and interaction. That so much needed interaction can be delivered through telepsychiatry, not only within CBT. Most applications within e-mental health can become more accessible to its users through telepsychiatry once we learn how to use the technology. At the beginning of this century, more remote psychotherapy was described as reliable and comparable to in-person therapy. The provision of psychological services via video conference is called telepsychology and has been described and documented last 20 years. Supervision and psychoeducation of those who work with mentally ill individuals at remote locations by use of video conference in real time has been described in several articles ever since 1998. Telenursing has been described since 2002, related to both clinical work and remote supervision. Telepsychiatry is particularly interesting in psychogeriatric services, parallel with development of so-called telepsychometry, a remote psychometry consultation in clinical gerontology invented in 1996. Remote services to elderly homes or to patients in their own homes have been described 20 years ago. Telepsychiatry in forensic settings like prisons and correctional institutions is highly appreciated and useful, especially for remote evaluations of involuntary treatments of prisoners. Current pandemic made inmates especially vulnerable as social distancing is not easy to maintain in overcrowded prisons. Along with COVID-19, the inmates have to deal with mental health consequences of the pandemic as well. Benefits of telepsychiatry in disaster scenarios has also been documented and is notably applicable in the context of the inevitable psychological sequelae it results in. However, its use has previously only been considered when dealing with a relatively localized disaster. The widespread nature of the current COVID-19 emergency is unique and justifies global use of telepsychiatry services, as well as increased international collaboration that unfortunately is limited due to regulatory constraints. Back in 2000 in Denmark, I launched the first transcultural telepsychiatry service in Europe. It was Danish pioneer telepsychiatry project aimed to assess and treat refugees and migrants by bilingual clinicians through telepsychiatry, without use of interpreters. As we all know, mental health systems worldwide are not tailored to the needs of minorities. Therefore, ethnic minorities are usually assessed and treated through interpreters. My idea was to try telepsychiatry via bilingual clinicians who speak the languages of the patients, so that the use of interpreters could be eliminated. Transcultural telepsychiatry model showed to have a very positive effect on patient satisfaction, primarily because of no need for interpreters, easy communication with bilingual clinicians, no risk of misinterpretations and misunderstandings that could otherwise lead to misdiagnosis and consequently to non-optimal treatment suggestions. Furthermore, interpreters provided communication is more time-consuming for both doctors and patients, and finally, more expensive due to interpreter fees. The transcultural telepsychiatry model has also been described later related to assessment and treatment of Hispanics, Latinos, Asians, and Native Americans. The idea of using bilingual clinicians in Denmark was not easy to implement. At that time, we only had a few psychiatrists who were bilingual. Therefore, I invited my colleagues speaking Arabic, Turkish, Kurdish, Polish from Sweden. It was the first time ever that clinicians from abroad assessed and treated patients in Denmark through video conferencing in real time. The first international service, launched back in 2006, is still the only such service in the world. The international transcultural telepsychiatry model can be particularly useful in the current refugee crisis in the European Union, as well as anywhere else where bilingual clinicians are not readily available and where interpreters are still a common solution. Considerations related to international telepsychiatry are primarily based on licensure and national laws and regulations related to the location of the patient and the professional respectively. According to required licensing laws, it is common that the patient cannot be treated if he or she is not located in the same country as the psychiatrist. Many patients who already see a psychiatrist may be exposed to a significant disruption of care in the case of travel, work, or study abroad, as they would either be forced to see another professional licensed in the respective country or not see anyone at all. WPA's global guidelines for telepsychiatry discuss a recent phenomenon called the meeting in the cloud. It is up in the cloud we meet our patients while providing remote internet-based consultations. The location of the cloud is determined by the location of the internet server, not by the physical location of either the doctor or the patient. Conceptualization of the visit up in the cloud then may cause future changes in existing regulations. This momentum poses new challenges for licensing authorities and calls for international cooperation between decision makers related to the remote provision of mental health care in the future. Therefore, we encourage policymakers to start the work of creating uniform licensing rules, first regional and then global. Six decades of practicing and researching within the field of telepsychiatry have proved that it is comparable to in-person services in terms of reliability of clinical assessment and treatment outcomes. Sometimes we may be even more effective than in person when it comes to remote delivery of services to specific patient populations, such as individuals within autism spectrum, child and adolescent who are used on remote communication and the use of mobile devices, or cross-cultural patient population. There is a strong body of evidence for how telepsychiatry can be used to offer effective care in every psychiatric condition. Today we will mention some. Randomized controlled equivalence trials has been done 15 years ago, confirming the reliability and similar outcomes of telepsychiatry approaches in treatment of depression. Regarding ADHD, it is proved that children and caregivers experience greater improvements in outcomes when receiving telepsychiatry-provided assistance than children and caregivers who received traditional in-person treatment. The applicability of telepsychiatry to the assessment and treatment of patients with schizophrenia has been studied and described ever since the 1990s. High acceptance and reliability have been proven and results published in a number of articles. This only confirms the notion that even seriously ill patients can benefit from telepsychiatry when provided by competent clinicians within standardized service settings. This is important to remember, as we still nowadays may hear that paranoid patients, for example, are not suitable for telepsychiatry. If paranoid patients, as well as any other, get proper and easy to understand information about telepsychiatry, then the risk for paranoid thoughts related to video cameras will be significantly diminished. My first experiences with telepsychiatry go back to the beginning of this century when I installed video equipment at the closed psychiatric ward in Copenhagen. All our patients were within F20 diagnosed spectrum. I saw them via video once a week, while the rest of the week we had the treatment as usual in person. After 6 months, I conducted a satisfaction survey asking for whether the patient was paranoid toward the video camera. The answer I got from majority of the patients was the same. No, I wasn't paranoid because you explained everything to me before we started. But yes, I'm still afraid of those video cameras that I cannot see, but which are hidden. What I learned is that we may not underestimate the importance of detailed information prior to starting the course of telepsychiatry treatment, especially with patients who do not have previous experiences with such services. We may conclude that telepsychiatry leads to better outcomes, improved clinical experience, lower costs, and improved patient experience. But we must not forget that the satisfaction surveys explored the telepsychiatry via standardized standalone video equipment, as at that time we did not have video platforms and software like we have on nowadays sophisticated mobile devices. The question is whether this is the case for home telepsychiatry when delivered via media that limits optimal body language reading. Future research may provide answers to the level of satisfaction of both patients and professionals alike. Although telepsychiatry service is convenient for patients, before the current pandemic, the barriers from a clinician's perspective were most concerning. This is because clinicians serve as gatekeepers for implementation and sustainability of telepsychiatry services. A few of the many barriers identified by clinicians include data safety concerns, reimbursement, quality of practice, lack of experience with the use of technology, and difficulties in changing daily routines. However, current pandemic proved that the adoption of telepsychiatry does not require unprecedented efforts, but primarily the removal of regulatory barriers, which enables better access to care, reduced no-show rates, and increase the level of patient satisfaction. The professionals are able to adjust very quick when the strict regulations are waived. The professionals have also showed ability to change daily routines due to extraordinary circumstances such as COVID-19 pandemic. Recent experiences may pave the way for significant changes in the clinician's daily work when it comes to the use of telepsychiatry in the future. So, that was the first part.
Thank you very much, Dr. David Mucic. This was quite an enlightening lecture regarding the background and the applications, the attitudes of the users and the providers. And as you mentioned in your presentation as well, how much important is the use of technology, that was quite evident via the immensely impactful use of visual aid as well. So before we proceed to the second part of the lecture, are there any questions? You are most welcome to post your questions. The participants of our online webinar, you're all most welcome to please put up your questions so that we may get answers. either in the chat box or via if yes, sir. If there are no questions so far, so with the permission of Dr. Deva and Professor Dr. Mohammad Iqbal Afridi, I'd like to proceed to the second part of the lecture, which includes clinical implications and practical implications, limitations, etc. of telepsychiatry.
Would you like to have some comment or do you want to add some point, Dr. Deva?
So far, I'm so surprised, positively surprised that technology functions perfectly at my side also. Although I use mobile internet, which is not so good, but I hope that your broadcasting there was also perfect as here. So that is positive. Because usually we experience some difficulties with these here pre-recorded sessions, freezing and so. I'm trying to do this different than Zoom meetings to make it a little bit more active and dynamic. That's why I prefer pre-recording sessions. But while the session is going on, we can always exchange questions on the chat or whatever. So let's proceed to
That video was clear and it was the talk was comprehensive, therefore there is no question.
Great, great. Let's go further.
So now let's proceed to the second part of our section.
Telepsychiatry can benefit patients in a number of ways, such as improve access to care that might not otherwise be available, for example, in rural areas, and bring care to the patient's location. Telepsychiatry enables distance supervision of general practitioners, psychoeducation of caregivers and patients at the general practitioner's office, decreasing stigma of the patients and self-stigma of general practitioners as well. Improved collaboration between public and private sector may lead to better quality of care. We may not forget that stigma is the reason why at least 60% of all mentally ill never access the mental health systems. But if we offer telepsychiatry within general practice office, or even better in the privacy of patient's own home, we will probably reach a greater number of otherwise hard to reach populations, such as stigmatized children and youth, autistic persons, individuals with physical impairment, inmates, patients who avoid transportation due to phobia, ethnic minorities who does not speak the language of the host country. Finally, detained patients have right to get independent clinical opinion in the processes of detention, appeal, and enforced treatment. Finding independent expert in local area may be difficult, but technology knows no barriers. Telepsychiatry may reduce potential transportation barriers, such as lack of transportation or the need for long drives or phobia related to the transportation. Please take a look at following video to get an impression of difficulties that an agoraphobic patient experiences in daily life. You may imagine that such patient may benefit from home telepsychiatry. People with a relaxed relationship with alcohol and drugs can risk driving drunk or stoned and causing serious harm to themselves and others. Telepsychiatry may prevent such scenarios. Telepsychiatry reduces the need for time off work, childcare services, etc. to access appointments far away. Accordingly, telepsychiatry reduces no-show rates and decreases the risk of missing appointments. Telepsychiatry reduces direct and indirect costs and increases quality of life when compared to in-person care delivery. And we may not forget its impact on climate changes. No driving, no CO2 emission. Early detection and prevention are improved due to increased access to relevant care and resources. Remote treatment eliminates the risk of becoming infected or spreading infectious diseases to others when sitting in the overcrowded waiting room. COVID-19 is the latest, but not the only potential disease that patients and/or doctors can transmit to each other. Continuity of care is just as important as care itself. Seeing the same therapist, regardless of the patient's location, is now possible thanks to the technology. Meetings take up a lot of our time. Efficiency could be increased by implementation of video conferencing into working routines. Psychiatrists are at the risk of experiencing burnout due to emotional stressors related to the nature of the clinical work, occupational hazards, changing nature of service delivery, and increasing administrative pressures. Telepsychiatry may act as one way to enhance psychiatrists' well-being and job satisfaction through the flexibility it offers. Telepsychiatry may reduce the risk of burnout through creating an increased sense of control over the psychiatrist's schedule. Further, through its remote nature, telepsychiatry reduces some of the occupational hazards associated with the practicing psychiatry toward violent or agitated patients and difficulty fully detaching oneself from the emotional stress of in-person patient encounters. A shortage of doctors, especially in small towns in rural areas, means patients can get timely care. However, telepsychiatry helps recruitment of scarce resources so that relevant care is easily accessible to previously underserved areas and patient populations. In comparison with advantages, there are only few limitations related to telepsychiatry. In general, these advantages are primarily related to limited opportunities for somatic examination. However, this may be improved by improved collaboration with general practitioners, so-called shared care model that we already mentioned earlier, or psychiatry nurse and young doctor visiting the patient at home and performing somatic examination. Usually we meet the patient for initial interview in person and perform the somatic examination. However, initial in-person meeting is not mandatory and depends on the doctor's experiences and skills related to telepsychiatry. Electric power failure or disrupted internet connection are unpredictable obstacles. In order to avoid potential complications, we must have prepared a backup plan that involves other real-time communication equipment such as telephone. Further, it may be necessary to reschedule the consultation. Potential consequences of practicing telepsychiatry are occupational, social, and academic isolation. To prevent this, the clinician must actively plan social activities. Moreover, engage in activities beyond work, such as personal interests and hobbies. Incorporate the combination of telepsychiatry and in-person psychiatry, so-called hybrid model, as a way to take advantage of the convenience and flexibility of video conferencing while avoiding isolation. More specific limitations are related to home telepsychiatry setting, which is clinically unsupervised setting. It means that the patient is seen in his own home without any medical staff readily available. In such a situation, the telepsychiatry limitation may be caused by the patient's potential personality disorders. Some patients may record the session and publish it on internet. That is why we must, prior to each session, remind the patient that no recordings are allowed. It is mandatory to have a signed consent prior to the course of telepsychiatry. Mobile devices are accessible and affordable. This makes them perfectly positioned for the delivery of home telepsychiatry. However, such an approach has more disadvantages in comparison with institutional telepsychiatry. Technical limitations of home telepsychiatry are related to equipment selection. Video platforms installed on patients' mobile devices operate via a built-in camcorder. Such a camera does not allow pan, tilt, and zoom functions. Consequently, it results in limited ability to read the patient's body language. Further limitation of built-in camcorder is a mirroring picture. Left is right and right is left. We notice it typically by the lettering version on the patient's t-shirt. Mirroring picture is non-significant obstacle as long as the clinician is aware of this phenomenon. But if not, then it may play a significant role when the patient, for example, presents left-sided paresis due to stroke, which shows to be right-sided paresis once we meet the patient in person. That is why it is important to be aware of mirroring effect while observing the body language. On many video softwares on mobile devices, the mirroring is turned on by default. However, not all video platforms do have a button for turning the mirroring off. That is why the standardization, interoperability, and intercompatibility between different video platforms and standalone equipment are some of the main challenges for the video equipment producers. The use of pan, tilt, zoom standalone video equipment is the only way to read body language during a telepsychiatry session. Example of telepsychiatry golden standard we may demonstrate through following video. Here you can see how much of the body language we may observe while talking to the patient and simultaneously use the remote control functions. As you see, we can come much closer to the patient without he notice it than we could do during in-person consultation. However, we cannot expect patients to buy the expensive standalone video equipment, but over time, equipment prices will continue to fall. Hopefully, within a few years, standalone equipment will be far more affordable, making it possible to increase the quality of video performance, primarily in the home telepsychiatry settings. Unfortunately, during COVID-19 time, we have seen a number of mental health institutions using video platforms and devices with built-in camera or simple webcams instead of standardized pan, tilt, and zoom equipment. Use of such equipment limits the reading of body language and may adversely affect patient and physician satisfaction and willingness to practice telepsychiatry in future. Telepsychiatry is apparently a valuable tool capable of increasing the access to care and its quality, enabling remote exchange of expertise. But the benefits of telepsychiatry may be fully achieved only by clinicians with relevant skills and competencies related to the use of the technology. Competence training should be a mandatory prerequisite for the use of technology in daily practice. We may not drive the car without a driver's license, even when we are good drivers. To maintain and even increase respect for our profession, we may not perceive technology as something that anyone can use without basic knowledge and skills. Unfortunately, that is exactly what we have seen in the case of telepsychiatry ever since the current pandemic outbreak. Frameworks for telehealth training and faculty development already exist, although few have been implemented today. WPA Telepsychiatry global guidelines, as well as this course, are only the beginning. The urgent need for clinical training and skills building around telepsychiatry, as well as other mental health applications such as mobile apps, artificial intelligence, virtual reality, etc., will determine the influence that psychiatry can have in addressing the mental health sequelae of the current pandemic. Offering digital literacy and telepsychiatry competencies training can ensure that all clinicians have the knowledge and skills necessary to work at full capacity through new digital media. Telepsychiatry must be perceived and promoted as a supplemental tool to our traditional daily practices. Once we become familiar with the basics, we will realize that we have never been introduced to the tool that requires so little, while in return it gives us as much as is the case with telepsychiatry. Thank you for your attention.
Right. Thank you very much, Dr. Reva. Right. Thank you very much, Dr. Reva. I suppose we have some questions in the chat box. Is the chat box visible to you?
Yes, I have seen some comments here. And there is a colleague who is asking about how we can relate real emotions, telepsychiatry, and artificial intelligence. I don't know if I understand the question completely or is it more general. I have one interesting experience which I mentioned in my first book, which is titled Mental Health, published for Springer back in 2015. That is the experience that shaped my career, and it happened over 20 years ago when I started practicing telepsychiatry. It was a patient 300 kilometers away, which I never met in person. She was treated by Danish psychiatrist and Bosnian interpreter because she could not speak Danish language. She was a refugee. And then she asked me from the beginning, doctor, can the whole country see us now? You must remember at that time we did not have Skype. We did not know what video conference was. We were on TV, me and her, so she believed that it was TV transmission. So I said, of course not. It is only me and you. And then she said, well, I have something to tell you. And then she started speaking about her experiences during the war in former Yugoslavia, where she was raped 15 times. And she said, I've been treating now for 3 years by a Danish psychiatrist and interpreter, and I could never speak about the rape. I could never speak about the reason why I feel bad, because I was afraid that the interpreter will talk to his wife and then his wife will talk to somebody else. And at the end of the story, it will come to her husband who doesn't know anything. And the husband will leave her and their 2 children. During that session and 6 months ahead, we met once a week. She was crying and talking about horrible things that she could never disclose to her psychiatrist in person because of the presence of the interpreter. This little episode or anecdote shaped my career because I realized that despite the distance, geographical distance, we can establish closeness, emotional closeness. In the moment we have a good connection with the patient, in the moment we have the same culture or language, and so on and so on. So I think that when it comes to emotions, telepsychiatry can offer a lot compared to traditional in-person communication, especially when it comes to treatment of autistic patients who prefer distances, when it comes to treatment of children and youth who are using mobile devices, and when it comes to refugees and migrants, which are my primary focus group, who are treated by interpreters. Interpreter in relationship is one too many. I don't think that there's a place for interpreters in psychotherapy, especially, but preferably nowhere. However, we do not have bilingual resources, but now we do not have any other excuses which we had before. Now we have technology. In the same way we are sitting now, I would be happy to collaborate with you each time I get my patients who are coming from Pakistan. We have no doctors speaking the language. So my goal is to increase the international collaboration. And I think that National Psychiatric Association's goal, one of goals should be to set up the requirements for telepsychiatry. For example, competency training of 3 hours or 1 day or something. As I said, we cannot drive the car without driver's license. We may have competencies before we practice telepsychiatry. I don't know if it was a long, long answer or trial to answer on these questions which I've seen.
Okay. Doctor, I have 2 questions. First of all, there are robust information and data available about the usefulness of the telepsychiatry. But I have 2 concerns. One is the ethical aspect and the legal aspect. Ethically, for example, if somebody is talking from the drawing room and she or he is not at the age of 18 or below, so in that case, if somebody says that someone who has recorded this and has been taken to any other places and they want the confidentiality, one aspect, this please discuss. And the second thing is legal aspect. Suppose I am sitting in Pakistan and writing a prescription for Dubai. So will they allow the authenticity of the prescription? They will not get the medicine from that country until unless they fulfill the criteria to have a registered person at that country to write the prescription.
Excuse me.
Yes.
Ma'am है या
Hmm.
woman?
Achha. Yeah, please, can you respond to these 2 questions? The ethical aspect and the legal aspect.
Of course. Prescription, I would
Excuse
say
me, ma'am है या man?
somebody is asking something more.
Let's mute her.
Yeah, okay. Regarding the prescriptions, I think that we should focus more on the collaboration with our general practitioners. And I think that each time we have a patient in the other country who requires medication, it will be good to send a note both to the patient and to his or her general practitioner, and which could prescribe the medication. That is the less a problem. While the other thing that you are mentioning, ethical aspects, I think it is. We must remember that we have to follow the rules as with in-person consultations. If we have children underage, it is usual that they are followed by their parents or that they have permission of their parents and so on. Regarding the recordings, it is true when it comes to home telepsychiatry, there is a risk, and that is why it is important that the patient get written information and written consent, whereof it is written that no recordings are allowed. Of course, there are no legal consequences, but it will be good to agree with the patient, please don't do this, although we know that we risk abuse, especially with borderline patients, personality disorder, and so on and so on. But on the other hand, I will say it makes us doctors more cautious for each word we say, for each way we behave. Think about what you are doing. Think about when you speak on the video that your wife is not cooking behind you or the children playing. And so I think there are many more things to learn, not just how to talk on video, because telepsychiatry is not only the video conversation. There is before, during, and after the session, the whole package of activities.
Yeah, huh? Ali Mufti want to ask some question? Yeah. Dr. Ali Mufti, would you like to ask?
Assalamu alaikum. It was a really nice presentation by Dr. Devar. I think he has set a trend for these virtual meetings and presentations. The content of presentation was very amazing, but the style of presentation, the video editing was very remarkable. And he has set a new trend for youngsters, for like us, especially for me. in virtual meetings. If you want to present in virtual meetings, so we can adopt his style. I had a question, but Professor Fidi, you asked the same question from Professor Dr. Devar, and he answered my query. Just to add to your question, I wanted to ask, in physical interviews, when our patient comes, it's very easy, because in physical interviews in our clinics, it's an exclusive meeting, a one-to-one meeting, and it's easy to control a patient's emotions. Especially if I give you example, the patients come, and if he is not able to control his emotions, if the patient he or she starts weeping, we can control her weeping spells, or we can give her tissue papers, which is very basic, but it helps to make a repo. This is not possible in video telepsychiatry. Another thing for me is that closure. We give appointments to the patient in telepsychiatry, video psychiatry, that you have been given a slot of 20 to 30 minutes. But the patients, they do not comply to the timings, and they take additional 10 to 20 minutes. And then we have another appointments waiting on. So it's very difficult for youngster, for like us, to close the video telepsychiatry. So could you just guide us, Dr. Devar, in this regard? Thank you.
Thank you for these nice comments and questions. I think they are very relevant. What we may not forget is that telepsychiatry is imitating the real life. Okay, so telepsychiatry should be the perfect imitation of in-person consultation. That means that the same rules and regulations that are valid for in-person consultation, we may use in telepsychiatry. When it comes to the length of consultation, we must advise the patient in the beginning. We have 20 minutes, and then 5 minutes before the end, remind the patient, now we have only 5 minutes left, please let's round the story. That is so. I can see now during this presentation today that you there in Pakistan at the conference, you have remote controlled standalone video equipment so that you can zoom in and out. And so it is so important that we are aware of the differences between standalone equipment, which enable the doctor to read the fully body language even better than in person, because we can zoom in so close to the eyes, compared to home telepsychiatry and web platforms where we do not have the opportunity for zooming and moving the video camera. And of course, some things will not be able to do on distance. But I think it is always important for us to focus on what the advantages we do have, because there are a number of disadvantages in our traditional in-person approaches as well. So nothing is perfect, and not one size fits all. What I think we shall conclude today is that hybrid model, which means in-person and technology-based supported, should be combined. And that is what I believe we will see much more in the future.
Thank you, Dr. Devar, for the comprehensive response. Next, we have questions from Dr. Mia Mukhtar. He would like to ask about data production in online consultations. So if you could please enlighten us about that.
About
data protection while in online consultation. What about the protection of data?
Visible here.
We may ask Dr. Mukhtar. Kindly, Dr. Mukhtar, unmute yourself and ask the question.
Well, thank you. Well, thank you very much, Dr. David. And in Pakistan, the pioneer of the telepsychiatry is Professor Iqbal Afridi, and we are thankful to him for arranging this session. My question is this, that while we are doing online consultation, then I would be more worried about the data protection, because we'll be like, in the online consultation, we are not like, don't know that this online session is something which is really confidential, or is or the data of the patient and all these things which is imported, I mean, is it protected or not? So I mean, my question would be like, about the data protection of the online consultation.
Of course. The question is so crucial because concerns related data protection were most common obstacles for widely adoption of telepsychiatry within last 20, 30 years. Telepsychiatry existed for 60 years. But we were always concerned about data protection of reasons that were not obvious, because since I started working back in 2000, we used encrypted connections. It is technological term. The connections are encrypted, which means that they are safe. Nowadays, we have other technologies like video platforms. Zoom is one of video platforms, as well as Viber, Skype, WhatsApp, and so on. The most video platforms are unfortunately not completely safe. That is why video platform producers are encouraged to make video platforms that are safe, number one, and number two, platforms that are interoperable and intercompatible with each other. And so far, we have not seen such platforms. There are few platforms which I know about, which are perfect and good and can be implemented into electronic patient journal as well. And that is also important when the hospital is purchasing the video platform, or when us colleagues, professionals, are using video platforms to know whether the connection is encrypted and safe. And if we know that, then we can also send some data or not. But it must come from up somewhere. Is it National Psychiatric Association, or is it the governmental? I don't know. That we must know and have some requirements, some regulations and some requirements we must have while we are meeting each other on Zoom like today, or treating patients through Viber and WhatsApp, which are absolutely non-safe and non-professional. So, Corona time, COVID time was the point when we were pushed into 21st century, 20 years later, but better late than never.
If there is no question, I would like Professor Dogar to give his comments, and we are very thankful to Dr. Imran, would you like to say something? Dr. Imran,
thank you very much, sir. I'll just pay my thanks to all the organizers and to the speaker. And because I'm myself practicing telepsychiatry and have found it very useful, and this session added further to my knowledge. Thank you very much, sir.
You're welcome. There is one who is called He wrote here that he agreed.
Thank you very much, Professor Vidi. Can I speak?
Okay.
It's a course, sir.
Dogar. Ji, Assalamu alaikum ji, Professor Dr. Imtiaz Dogar ji. I just wanted to pay formally thanks to our speaker, Dr. DM. Very thankful of the talk, and it was very relevant and need of the time. Although I joined late, sorry, I was busy in some other university meeting. But our participants, they have very actively participated. And we are thankful to Professor Afridi and his team who have organized this wonderful sort of event. And again, formal thanks to our speaker. Thanks a lot.
I hope that we will meet each other at some of the conferences in the future somewhere. It was a pleasure really to be with you today. And you may have regards from Europe. Bye.
So before we give you a formal certificate of a token of appreciation, let me appreciate the efforts of our organizer, Dr. Faiza and Dr. Muzammil, and a good clapping for them. They have organized very well. And now let me present this certificate to you, Dr. Devar, for recognizing your great service throughout the world. Globally, you are authority on the subject. And thank you very much for giving us this time, your precious time. Thank you once again.
Clapping again, clapping again.
You're more than welcome.
Thank you.
Have a nice day. Bye.
We will again talk on another platform, inshallah, because you are planning to have some thing on the World Psychiatric Association. So probably we'll meet there again. Okay, thank you so much.
Of course, I will send you the information, and then let's see what the National Psychiatric Association of Pakistan will do or can. Of course, we will collaborate. Thank you so much again. Have a nice day. Enjoy.
Thank you.
Thank you.
Department of Psychiatry, to all the participants who joined us for the session. We'd like to formally end the session now. Thank you very much.